Good day, my name is Imelda Williams. This presentation will focus on abnormal radiographic appearances that will include the shoulder girdle and the upper limb, and this is part B, which follows on from part A. So please ensure that you first work through part A before you view this part B section. Before you view part B, please ensure that you've worked through part A, as part A will also have the learning outcomes as well as all the resources that you will need for the shoulder and upper limbs. I've added some additional projections. A wrist view with a radial deviation will show the carpal bones on the ulnar side and the spaces much better. When you do a radial wrist projection with ulnar deviation, it opens up the carpal bones on the radial side and especially the scaphoid. The carpal canal view is used to, for example, if you want to make sure whether there is a hook of hamate fracture or pisiform, and it also shows the tubercle quite well of the trapezium. The wrist has got quite a lot of ligaments to maintain stability, and here I've just given you a slide that shows the dorsal ligaments as well as the volar ligaments of the wrist. So back to our ABC systematic assessment. So for adequacy, there's a number of views that you need to check to ensure that you can exclude any additional fractures. For example, if there's a high suspicion of a scaphoid fracture, there should be additional scaphoid views. For the alignment, you need to check the relationship to individual bones on all of the projections so that you can exclude dislocations. Again, when you get to the bone, you need to search for steps or breaks in the cortex and then also check the trabecular patterns for changes in density. As there are a number of joints, it's really important that you check for uniform joint spaces. So check for signs of disruption to the three arcs, the Galula's arcs, and then in the soft tissue, check for soft tissue swelling or foreign bodies. So on the lateral view of the wrist, we have a soft tissue sign, which is the pronator quadratus fat plane. This can follow when a fracture has occurred, and the pronator quadratus fat plane can either be displaced anterior, or there could be blurring, irregularity, or it could be completely obliterated. However, the pronator quadratus fat plane does not indicate, similar to our sail sign, that there is definitely a fracture. It just shows that this is the area where most of the impact of the trauma has happened. So the types of fractures that we need to look for would be Collie, Smith, Spartans, or scaphoid. And in terms of wrist alignment, we need to look at lunate dislocation, perilunate or midcarpal dislocation, and then also pediatric fractures. If you draw a straight line through the middle of a lateral view of the wrist, the line should bisect the capitate, which I've indicated as C, and the lunate as L, and then also the distal radius. This is referred to as the apple, which is the capitate, sitting in the teacup, which is the lunate, and resting on a saucer, which is the radius. However, you also need to look at alignment on the PA view. And on the PA view in an adult patient, the joint spaces should be equal or less than 2 millimeters. Ligamentous injury can result in an abnormal gap, and the gap normally occurs between the scaphoid and the lunate. Now, this is called the Terry Thomas sign. I'm not sure if any of you know the chap in the middle, and he was a comedian of the UK, and he had this lovely gap in his teeth, and that's where this was coined. However, some of the later textbooks might call this the Madonna sign. She doesn't have such a big gap, but in any case, some of the books think that this should now be called the Madonna sign. The first wrist dislocation we're going to look at is perilunate dislocation. So peri means around. That means that the lunate is still in contact with the radius, but the capitate has dislocated dorsally from the lunate, and you can see that in the drawings as well as on the images. On the PA view, you will find that your proximal row has been disrupted. The lunate might have a slight volar rotation with a perilunate dislocation. With the lunate dislocation, the lunate has now dislocated volarly, and you can see when you draw your line is that we miss the lunate completely. It also results in disruptions to the arc. With midcarpal dislocation, the lunate lies volarly, so it's subluxed, but the capitate is dorsally subluxed. The zone of vulnerability indicates where trauma can occur following a Fuchs injury. So I've drawn an arc there, and it passes through the radial and ulnar styloid processes, and then the scaphoid, the capitate, the hamate, and the tracheotomy. So if abnormality is detected within the arc, you should search carefully for other fractures or dislocations. Colles fracture is quite common. So it's a transverse fracture of the distal radius with the distal fragments displaced dorsally. On this image, you can see on the lateral view the displaced fragments dorsally. On the PA view, the only thing that you can pick up here is that there is an increase in density at the level of the fracture. Also in this case, you can see that there is an avulsed styloid process fracture. Smith's fracture is an opposite of the Colles. That's where you fracture at the transverse part of the distal radius. However, the displacement is palmar or anterior, as in this case. Barton's fracture sits exactly at the same spot where we would expect either a Smith's or a Colles fracture. However, it involves the articular surface. If it involves looks like a Colles fracture, it's called a dorsal Barton's, or if it looks like a Smith's fracture, as in this case, it's called a reverse Barton's. So it's an intra-articular fracture of the distal radius. Scaphoid fractures are important, especially if the fractures are across the waist of the scaphoid, because of the risk of avascular necrosis, as the only blood supply to the scaphoid is via the distal pole. There is a classification of scaphoid fractures, and it's according to the anatomy. So the most common is through the waist at 70 to 80%, and then also the proximal pole. But you could also have fractures of the distal pole or the tubercle. On the X-ray image on the left, I've just included the scaphoid fat stripe, which is often seen with scaphoid injuries, and on this image you can see there's a fracture through the waist of the scaphoid. Radial fractures have been classified according to Reichman, and it ranges from a transverse fracture of the distal radius to intra-articular. And then if we look at the images at the bottom is where this intra-articular but also compressed fractures, as well as fractures involving the styloid processes. Another fracture is Hutchinson's, or it's also called Shaffir's fracture, and it's an intra-articular fracture which involves the radial margin of the distal radius as well as the radial styloid process. Carpal instability has been described according to the carpal ring theory, and carpal mobility is controlled at the radial, which is the scaphotrapezium, and the ulnar, which is formed by the tracheotohamate links. A normal scapholunate angle should be between 30 to 60 degrees, And a a normal capitolunate angle should be between 0 to 30 degrees. So at the image at the top, it shows the links between the scaphotrapezium, the radial link, and then also the ulnar link, which is between the triquetrum and the hamate. If there's a break in the ring, it can result in uncontrolled mobility, and the lunate will tilt either dorsally or volarly. Now, there are two types described with the dorsal intercalated segment instability, or DISI, the most common. The cause is either bony or ligamentous disruption on the radius side, and this then results in a volar dorsal tilt that is greater than 30 degrees, or a scapholunate angle that is greater than 60 degrees, as we can see in this diagram. VISI is then the volar intercalated segment instability, and this is where there's bony or ligamentous disruption on the ulnar side. The scapholunate angle is now reduced to 30 degrees, and the capitolunate angle is increased above 30 degrees, and we can also see that on our X-ray images at the top. Now moving to the hand, and here I've included additional hand projections. This is also called the ball catchers projection, so that you can demonstrate the metacarpal joints much better. Metacarpophalangeal joints, sorry, much better. So looking at the hand, again, important that the correct images have been taken. And especially when we think about the fingers, so for the thumb, you should have dedicated views. It's important when you look at alignment that you check the relationship to the individual bones on all of the projections, and then on the lateral view to be able to exclude either dislocations or subluxations, especially at the carpometacarpal joints. With the bone, once again, trace contours for any steps or breaks in the cortex, and then check the trabecular pattern for changes such as lucent or sclerotic changes. And then vascular grooves, be aware of that. It's grooves that you see from the margin, from the cortex up to the middle, and it can mimic fractures. There's lots of joints that you need to look at, so make sure that you check each of those for uniform joint spaces, and then also for any narrowing. Be aware that the technical issues due to positioning of a patient's hand can affect the joint spaces. And then in the soft tissue, to check for soft tissue swelling and foreign bodies. It's important to distinguish between extra versus intra-articular fractures when you look at the metacarpals and the fingers. Phalangeal fracture dislocations can result in reduced motion and significant loss of function if they have not been identified initially. The most common metacarpals are the first and the fifth when it comes to fractures, and metacarpal fractures makes up about 30 to 40% of all hand fractures, with the fifth metacarpal the most common and making up about 10% of all hand fractures. So the mechanism of injury can involve a number of forces. So it could be crushing, twisting, or revulsive. You could have fractures to the tufts or to the shafts, or avulsion fractures near the joint space, a joint area where you could have either phalangeal dorsal or volar corner avulsions, and then of course dislocations or subluxations. So the first one I want to talk about is Boutonner's deformity. So here we have flexion of the proximal interphalangeal joint, and this is then combined with hyperextension at the distal interphalangeal joint. This patient, when the patient presents, the patient cannot straighten the finger at the PIP joint, and the fingertip cannot be bent, and normally there's quite significant swelling and pain. Bennett's fracture is quite common, so it's at the base of the thumb, and it's a two-piece fracture, but it's a two-piece intra-articular fracture. It's also important to exclude whether there's a dorsolateral dislocation at the base of the thumb. So Rolando's fracture is also at the base of the thumb. However, it's a comminuted fracture, and the appearance of the fragments could either adopt a Y, a V, or a T configuration. In this image, you can see at the base of the thumb that it has adopted a Y configuration. Boxer's fractures are commonly known as a punch injury or a brawler's fracture. The most common area for boxer's fracture is either at the neck or the shaft or of the fourth or fifth metacarpal. So on this image here, we have a volar or palmar angulation of the distal fracture fragment of the neck or the shaft. A mallet deformity is the result of forced flexion of an extended finger, so you would quite often find it with basketball or netball players, and it results in a tear to the distal end of the extensor tendon. This patients, if they present at an emergency department, are unable to voluntarily extend the distal interphalangeal joint. So on this image, there's drooping of the terminal phalanx, and commonly there will be an avulsion fracture of the dorsal aspect of the base of the terminal phalanx. The next injury is a skier's or gamekeeper's thumb, and what we see in these patients are that there is an avulsion fracture on the ulnar aspect of the first metacarpal phalangeal joint. It could also have a subluxation of the first metacarpal phalangeal joint. Here we can see on the diagram in the middle and then on the image on the right. Carpal metacarpal joint dislocations can be the result of fractures through the bases of the metacarpals, and this involves especially the first and the fifth carpal metacarpal joints. Phalangeal fracture dislocations tend to be mostly dorsal, so the dislocations are also associated with fractures. They can result in reduced motion or significant loss of function if not correctly diagnosed. Crush fractures to the digits commonly involve the terminal tuft. However, if there's a nail bed injury, this should be treated as an open fracture, so it should be seen as a compound fracture. Then finally, just a few points on pediatric fractures. Pediatric bones have inherent elasticity. The fractures are usually incomplete. Importantly is the Salter-Harris classification, and to remember that not all fractures are green stick fractures. A torus fracture is a variation on a green stick where the cortex folds upon itself and produces a slight irregularity. However, there's no break in the cortex. So here's a few examples of pediatric fractures. You could have a complete fracture where you have got a break in both the cortex, or a green stick where there's only a fracture on the one side, or a torus where there's a bulge but no break in the cortex, and then you have a lead pipe where there's a bulge and then also a fracture on the one side, and then bowing of the limb. So torus or buccal fractures, this is a result of compression failure at the junction of the metaphysis and the diaphysis. They can be very subtle, and it's very common in the distal radial metaphysis. So the cortex folds upon itself, so what you need to look for is just a bulge, or it looks like a step in the cortex, but no break in the cortex. However, green stick fracture is an incomplete fracture, and you have a fracture on one side of the cortex and the opposite side is bent. So in the image on the left, you can see that there is that bulge, but there is no break in the cortex, and that's typical of a torus fracture, whereas on the image on the right, we can see there's a break on one side of the cortex, so there is a fracture, however, the other side is intact. So some of the other pediatric fractures, so complete fracture can be classified as spiral, transverse, or oblique. And lead pipe is a combination of a green stick and a torus, and bowing is acute plastic deformation, and this can lead to increase in longitudinal stress. So here we have plastic bending or bowing, where we have abnormal bending of the bone but no break in the cortex, and this is seen only in paired long bones. Growth plate injuries can involve the epiphyses and the metaphyses. Injuries to the germinal layer of the cells can lead to complications such as bone growth discrepancies as well as long-term disabilities. Salter-Harris type 1 and 2 does not generally involve the germinal layer and has a good prognosis, whereas with type 3 the germinal layer may be damaged, and type 4 and 5 will interrupt the growth plate. I've given you the Salter-Harris classification, and this is according to Otto Chan, and you could use the mnemonic Salter, where the S is type 1, which is slipped, type 2 the A is above, and then type 3 is the L, which is lower than, type 4 is through, so it's the T, and then type 5, if you compare type 5 to type 1, it looks very the same. However, this is a compressed fracture, so it's a rammed fracture, and this is the worst of the Salter-Harris type fractures, and it is quite easily missed. So in these images then, we have from going from the left to the right, we have slipped, and then on the second image we have a fracture that is above the growth plate. In the middle image, we have a fracture that is lower than the growth plate. And then in the fourth image, we have a fracture going through the growth plate. And then in the fifth one, we can see that increase in density. And that increase in density shows that it is a compressed fracture or rammed fracture. And that has the worst prognosis if it has been missed, because it can result in discrepancy of bone growth. Kienbock's disease can result from either a single or repeated trauma to the lunate, and there can be an impaired blood supply to the lunate, which can result in avascular necrosis. So on x-rays, you could maybe see a subtle linear fracture. This then increases, and this lunate becomes more dense or sclerotic. Eventually, as in the diagram in stage 3, the lunate loses height. And then in stage 4, we have where there's disintegration of the lunate. So the take-home message after the two parts, part A and part B, is that you should always apply the ABC search strategy when you interpret radiographs of the upper limb and the shoulder girdle, so that you are able to distinguish between what is normal and what is abnormal. You also need to apply alignment principles to specific body regions so that you can identify whether there's a dislocation or subluxation. Soft tissue signs are important, as that could indicate the presence of fracture. You also need to know some of the common fractures associated with the upper limb and the shoulder girdle, and then also to identify pediatric traumatic conditions as well as common pathologies that's associated with the upper limb and the shoulder girdle. Thank you.